Are you hormone curious? For women that are in their 40s, 50s, and 60s, we get so many questions about when to use hormones. Should I be testing hormones? What happens when my doctor doesn't want to talk to me about hormones? And I have an interview today that I think you're going to really like. I interviewed Dr. Bonnie Gasquet, who is a hormone specialist. She's an internal medicine doctor, and she has such a great perspective on when and how to start hormone replacement therapy, or how to potentially test and delay hormone therapy until needed later in life with some other strategies. So she is a wealth of information. We go into some details on estrogen and brain health and heart health. How old is too old to start estrogen therapy? We talk about testosterone. We talk about hormone therapy and breast cancer, all from her perspective and a little bit from mine. So if you're interested in hormone therapy, again, if you're hormone curious, or if you're not sure that what you're on is the right thing for you, check out this discussion with Dr. Bonnie Gasquet. I think you're really going to enjoy it. All right, Dr. G, so good to have you here on the Dr. Doug Show. I have so many exciting things that I want to talk to you about that I think people are going to really enjoy. But first, will you tell the audience a little bit about your background, how you got to where you are, and what your practice is like now?
Yes, thank you. I'm so happy to be on your show. So I'm Dr. Bonnie Gasquet, but everyone calls me Dr. G. I'm an internal medicine physician by trade, but I went on to have a focus in hormone optimization therapy and peptide therapy. I don't think we discussed that. I was a hospitalist for the longest time. After I finished residency, I worked as a hospitalist, actually a nocturnist, and I also taught academic medicine at Tulane Med School for a few years, in addition to building my own private practice. And what I noticed was, when I was a hospitalist, same story as many of us have, I'm getting the patient with the end disease, and I'm trying to save a life in that moment. And so at some point, it's kind of like, where's the system broken? And it's broken in many places. But I, at some point, through, I guess, observing other mentors, realized, look, there's a big deal in root cause, and there's a huge deal with hormones. So I kind of went on that track with A4M as far as getting certified in hormone optimization therapy. So I still practice as an internal medicine physician, but my focus and my heart right now is in hormone balance, hormone optimization, and kind of keeping all of our other organs in good health so that we don't have those end stage chronic diseases so early.
Yeah, that's beautiful. And that is a story I hear frequently as doctors are trying to find, how can I help people the way that I want to help people? And I had a very similar pathway in A4M was the group that I used as well to get that additional training. So it was really, really helpful. And I know that also means that we're going to speak the same language as we move forward with this conversation.
Yeah.
Yeah, cool. So the area that I really wanted to spend some time on, because I try to keep these relatively brief, and interviews are always a little bit longer, but I recently did a video with Dr. Michael Twyman. Do you know him? He's a cardiologist in the functional space.
Yes, I believe so. Yes.
Yeah. So that was a really fun conversation, and we got into a little bit estrogen, and we got into cardiovascular prevention from a cardiologist perspective. So that was cool, and it was very techy and in depth. But what I wanted to get from you specifically around estrogen is I wanted to dig into some of the terminology you use, and then I want to dig into really heart health and brain health specifically. We didn't talk about brain health at all with Dr. Twyman, but you used the term hormone retention. And I wanted to let you explain that, because I've never used that terminology. So I want you to explain that for the audience, and then we'll pick it up from there and figure out where to go.
So the term hormone retention, I guess you can relate it to the fact that as we age, we all make less and less and less of certain hormones and enzymes and antioxidants, and pretty much we make less and less of everything. Specifically the hormones, your sets of estrogen, your progesterone, your testosterone, but also thyroid and things like that. It relates a lot to what are we putting in our body? What are we doing to our body? We waste hormones in a certain way. We don't provide our body with the building blocks for hormones in a certain way. It's funny that you spoke with the cardiologist. Some patients maybe don't deserve a statin. They're blocking their building blocks, and which means that they're kind of blocking their ability to make a certain amount of the hormone.
Mhm.
And coincidentally, when you fix one end of the hormone spectrum, it actually helps balance the cholesterol spectrum. So there are a lot of things that we do to ourselves and environments that we put ourselves in, stressful environments, for instance. We're not going to make as much progesterone if we're making too much cortisol, or, testosterone if we're making too much cortisol. We do a lot of things to ourselves, and we put ourselves in a lot of situations that maybe help us flux in ways that we don't really need to. So we waste hormone there, in addition to not being able, just the aging process in general. And we don't hold on to a lot of the hormone, which means the receptors, and people forget about receptors, the receptors that are accustomed to receiving a certain amount of hormone, those receptors kind of go away if they're not used to getting that, they're not getting the signal anymore. So, which begets less and less hormone. So it's a vicious.
Yeah, a vicious cycle is a really good way to put it. Yeah, I like the term hormone retention. And then as far as it relates to, premenopausal, perimenopause women, and then getting into the postmenopause timeframe, how do you work with women to maintain, and then at what point are you talking about replacement?
Women have a spectrum. Men are so easy. I love my men. Women have a spectrum. A lot of younger women will come to me with maybe mood disorders or anxiety disorders or depression disorders and things like that. And it turns out someone slapped birth control onto them, and they've become this anovulatory state, and they have many hormone issues. And I tell them, look, the birth control pill itself is probably a large portion of your problem, but it served as a Band-Aid for a different hormone imbalance that could have been fixed differently. And then my younger women, they say, oh, well, I don't want to go off of the pill because I don't want to get pregnant. And that's a whole nother discussion. But one remedy for those patients is counseling them about the pill, maybe giving some supplemental progesterone at a certain time frame during their cycle, in addition to counseling on nutrition and maybe some supplements to help clean some receptors off and naturally balance the hormones they have as a young woman. So the early premenopausal woman, those are some self-inflicted issues that we talk about, and we can kind of fix those a lot easier. The perimenopausal woman, so this is when we haven't reached menopause yet, where our ovulation is kind of maybe getting more spread out, just irregular, abnormal. That woman is experiencing a lot of symptoms. And so a lot of women come to me if they feel those symptoms. So it's symptom control. But that's when I start to prep them, like, look, in the future, when you go through menopause, you're going to put yourself at risk for bone health issues, heart health issues, and your cardiovascular system. Like, I explained to them that estrogen plays a role in the breakdown and buildup of bone. It plays a role in where we shunt our fat distribution. It plays a role in what parts of our brain are vibrant and not vibrant. In all of them, play a role in our cardiovascular system as far as how pliable and relaxing are our vessels. Are we building up crud inside of our vessels? Are our blood vessels and our other muscle tissues hyperactive, constricting inappropriately, things like that. So I tell them, even though you don't have symptoms, or maybe you do have symptoms, at some point later on, the absence of your hormones are going to cause a problem that may be silent to you until it's a huge problem. So in the perimenopausal stage, I at least remind them, look, we can at least test your labs, see where they are, adjust what you might be doing in your day-to-day activities, adjust the ways that you're eating in addition to the types of food that you're eating, adjust your sleep schedule, your stress schedule, things like that. I try to counsel my perimenopausal women to maybe help retain, like my retention, retain as much hormone as they can until we have to truly replace it.
Yeah, I like that. That's a great perspective on it. So then let's dig into, you mentioned brain health a little bit, and this is an area where Twyman and I really kind of beat cardiovascular risk to death. And I do want to mention a couple of things there. And I talk about osteoporosis sort of ad nauseum with estrogen and the importance of estrogen. So let's talk about brain health, because this is an area that my patients will frequently have fear and concern, and most of them aren't doing anything about it because there just doesn't seem like there is anything to do about it, and they've never been counseled about the benefits of estrogen in brain health. And I'm writing a book right now, and I have a whole chapter on it. So I've been looking at the literature, but I still have some questions even after doing that deep dive. So I'd love to hear your perspective on it and how you counsel people on estrogen for brain health.
So with brain health, I guess the way that I start the conversation with my patient is I ask them if they've ever known anyone with Alzheimer's or dementia. And then more frequently than not, they do. And then I explain to them that throughout a female's life, we have a certain amount of estrogen, a higher amount of estrogen. If we're having natural estrogen, they bind to the estrogen molecules bind to different receptors. And there are certain parts of the brain that have different, like a one alpha or one beta. The cerebrum has more beta receptors than the hypothalamus. Well, our estrogen, when people say the word estrogen, they don't realize that we have three different estrogens as adults. The estrogen that is most active and beneficial is the estradiol. And that's the one that kind of goes to the cerebrum and the hippocampus and the amygdala that has us having good cognition and memory and fast thinking and things like that. Whereas the alpha receptor on the hypothalamus, that's the thing that kind of regulates your body temperature and all of the things that might be bothersome if the estrogen were taken away. Mm-hmm. So when it comes to brain health, women, again, it's a silent situation that catches us later on if it's not bothersome, right? So when women go through menopause, if they are fortunate enough to be bothered by hot flashes, that's what triggers them to talk to someone about it. But some women don't have those hot flashes, and so they're not bothered, and so they really don't complain about much to their primary care or to family or whoever. They don't complain a lot if they don't have the symptoms. Well, the silent, and I don't know if I would call it killer, but the silent part of your brain going sideways is that when that estrogen is withdrawn, those receptors regress. They have nothing more to do. If you're not stimulating them, they regress. And when they regress, those parts of the brain, you can see it on imaging. When they regress, those parts of the brain tend to shrink a little bit. So the hippocampus, you can see it's smaller. And the cerebrum, that's your cognitive function. I mean, you can do certain things throughout life. You can read, you can try to make sure that, you're doing things to stimulate your brain, try to live an anti-inflammatory life. But the estrogen receptors in the cerebrum are there, and estradiol is the one that kind of binds to those receptors and stimulates and helps our cognitive function. So when we take it away, it's blunted. And the other aspect of it is they've seen the estradiol helps to prevent those plaques that build up. Mm-hmm. So when women have lived for such a long time with an abundance of estrogen, and then eventually it goes away, we're at a higher risk of developing those plaques, which leads to Alzheimer's and the early onset dementia.
Yeah. Yeah. I wish the literature was more clear on this topic, because when I was looking for clear evidence to support the use of estradiol specifically for, dementia prevention, there's a signal, it's in there, but it's not a slam dunk. But, right. But clinically, I see it. I mean, women that we start on estradiol that haven't been on it, I mean, right. It's like almost every patient.
Yeah.
Right? It's amazing.
Because it's like night and day. It's literally, and I'm sure you've had these patients in your clinic where they've come in, or maybe I have like middle-aged patients that come in and tell me that their mother or their aunt or whoever is forgetful, or their doctor doesn't listen to them when they tell them, like, I'm forgetting names, I'm forgetting it's significant things. And then, you test and you give them just enough, not a baby dose, but there's a certain threshold where you need to protect bone, brain, and heart. It's not just to get the hot flashes away.
Right. Yeah. There's some interesting data on that. Do you have a target that you look for? Are you testing levels, and do you have a target that you aim for?
Yeah. So I test levels. Ideally it's not just to elevate the estrogen to a certain number. maybe like 100, mid 100, something like that. But really, I test the FSH and LH as well. So
Mm-hmm.
if it's like if I raise estrogen to a certain degree, but FSH and LH are still up here screaming for more estrogen, then I know I haven't done a good job. So I'll increase my estrogen dose. And I aim, honestly, FSH and LH, I try to get it around 10. I mean, I don't really want it up there screaming at all for more estrogen.
Yeah, that's interesting. I haven't used that approach yet. We go based off of estradiol levels.
Yeah.
And I don't think there's any right answer here. I think the right answer is do something different than the standard of care, which is if your symptoms of vasomotor, hot flashes, and night sweats are gone, then you're good. That's clearly not true. We're not addressing bone, brain, and heart with those levels. Because I see women that put on a very low dose, and they're like, oh, my hot flashes went away, and I'm like, great, but your estradiol level is 10.
Right.
we're not really doing much, and so yeah, I think I'm glad that you measure. I think that's really great. Let's switch a little bit over to then when we let's talk about heart first. So the reason why I want to bring this up a little bit is that one of the biggest challenges I have in my age group of patients, because we are almost exclusively bone health at this point. It's sort of like it's all that comes in the door. It's pretty much all we talk about, and it's all we kind of market. We don't really market, but it's all we talk about. Yeah.
Sorry. And I'm not sure if I don't think we've mentioned this before. How are your people coming to you? Are they coming to you because they've already been told they have osteopenia?
That's right.
Okay.
Yeah. So our patients are going to come in. They're going to be generally going to come in through YouTube. And then we have a free program that we're putting out. I think I don't know how many, like 7,000 or 8,000 people that are in our free program. It's awesome.
Yeah.
And then we have our HealthSpan Nation, which is sort of it's a weekly Zoom Q&A style, and we have 400 something people in there. So we're answering a lot of questions around osteoporosis. But then our patients are essentially all people that have a diagnosis. They're generally trying to reverse osteoporosis naturally. They don't want to use the drugs because the drugs have, let's just say, a lot of potential negatives. And so they're coming in with it. So we know that when we're talking about hormone replacement, we want to hit those thresholds to make sure that we are addressing bone, and then we're getting bone turnover markers to verify that. So I know the women that have an estradiol level of 10, their CTX or bone breakdown marker could still be over 1,000, right? So I know that it's not impacting bone.
Yeah.
But the challenge, this is one of the biggest challenges I have, and this is every single day, and it just, like, I wish this problem didn't exist. But with the timing of the Women's Health Initiative in the early 2000s, the timing of my patients who are now diagnosed with osteoporosis, who went through menopause at the time of the WHI, it is this age group of women that are in their early 60s to mid 70s that are 10, 15, 20, 25 years out from menopause.
Mm-hmm.
So I have a whole paradigm, and I talked to Dr. Twyman about this, and we kind of went down some rabbit holes on it. But give me your perspective on this. Do you have hard cutoffs? How are you managing that potential risk?
Hard cutoffs on age?
Yeah.
No, I don't have. I think it's inappropriate to deny a woman the right, or at least the option for treatment. If you think about it, after you go through menopause, we still make some estrogen. We make estrogen, we make estrogen in our fat cells, on our adrenals, things like that. So it's not that we're completely void of estrogen. It's kind of like what you were saying a while ago, when I call it the cute little patch.
Mm-hmm.
It's when women get that cute little patch. It's 0.625 milligram patch of estrogen. So women, if a 70-year-old woman walks in today and she said, I went through menopause 20 years ago, what difference is that from a woman that had a surgically induced menopause at the age of 30 and now she's 50?
Yeah.
Also, same thing. We still have a certain amount of estrogens in our body. It's just not enough to be protective. So for me to deny a woman a protective effort, I think, is actually first doing harm.
Yeah, I like that. It's this is where I struggle with it, which is because I have several patients that are in their early 70s and they've never been on hormone replacement. nobody would have a conversation about it. Yeah.
Before I throw them on hormone replacement, if they had not been on it and they're at that age, one thing I would do first would be gut health, also to help support their receptors. So there are a couple of supplements that serve for hormone receptor support. There's some gut testing. I want to make sure that, at least if I'm going to give them, again, I don't use oral estrogen, but I do use oral progesterone.
Mm-hmm.
If I'm going to give them estrogen and I want to give them a progesterone, I want to make sure that their gut is healthy. There is the estrobolome that we deal with as well. I do have someone that helps me with gut health issues, but before I just throw it at them, I do help them with receptors, and each person's different. But for the most part, to answer your question, I have no age cutoff.
Yeah, well, that's great. I don't technically either, but I'll do cardiac testing with them, and then we'll talk about risk, and we'll go down that thing. And if they have significant cardiac disease, I just bring it up and I say, look, there, statistically there's a risk.
And
it's low, and then I let them decide. And honestly, most women after 70 decide not to use it.
Yeah.
And that doesn't mean that we're not using potentially testosterone and progesterone, without estrogen. Like we just have so many levers we can pull.
Yeah.
And they look at that one and they're like, I don't think so. But many patients in that 10 to 20 year range where we are much more aggressive, they're denied it by the majority of their providers.
Right. I at least offer them the information and the education, and I go through their individual stories with them. And, it's their own choice, but I don't think that I don't think the conversation shouldn't be had.
Yeah. Right. And we have the conversation too. Yeah. Sometimes I feel like I'm the only one.
It's me and us. It's us.
It's you and me. Sorry to interrupt this interview with Dr. Bonnie Gasquet, but if you are watching this and you have osteoporosis, or you're worried about someone with osteoporosis and you're trying to figure out how to put together all of the information that you're getting on the internet into one place, check out our Masterclass. The Bone Foundation's Masterclass is the starting point for all of our free content, and it'll help you to figure out all of the things that potentially you can do to improve bone health on your own and what you might need some help with. So look for the link in the description below, or if you're listening to this on a podcast, go to optimalhumanhealth.com to learn more. So let's swing this around to testosterone. So I used to be a little scared of testosterone, probably like a lot of doctors, because, well, it's a controlled substance and, we're going to be on some list because we're prescribing testosterone. And then I went through my own low testosterone story, which I don't really share very often, but I've been on testosterone replacement for about 4 years off and on because I tried to fix it. I didn't fix it. And so I have become a big advocate, especially the more I use it, the more I see the benefits, the more I, look at the research on women, and you have to read between the lines, of course. But give me your sense of how did you get into testosterone? Because as an internal medicine doc, correct me if I'm wrong, but you were not trained in using testosterone.
We were not.
Right.
For that, I don't even remember that hour class that someone may have mentioned it briefly.
Yeah.
I got into testosterone as soon as I hit the A4M doorway. I mean, it was like Pam Smith is just like amazing, and just through the fellowship, I think it was introduced along with all of the other hormones when we discuss the downstream issues of when testosterone is absent. My main thing with women and testosterone is that if you're a mom, if you are someone that has a full-time job, a corporate job, a high-stress job, you're taking care of your elderly parents, maybe you have a house full of people. If you're stressed all the time and you don't have if you don't have testosterone, your cortisol is dominating, you are a hot mess. Your testosterone's gone, you can't manage stress. Your cortisol is so high, you're not producing that or progesterone in your adrenals. So you're not sleeping, you've got fatigue. I think it's not just estrogen that has to be replaced later on. As we age and as we go through our change, the testosterone is super important, not only for bone health and managing stress, but it's also important for our muscle mass. So the women come to me and, their body's morphing and they're collecting fat in certain areas and their mood's off and all of this. But metabolically, it's like, what are our hormones doing for us as well? You can't neglect testosterone. It's so helpful with muscle management and your metabolism in general, but you need your muscles to take in glucose you're going to end up with a complete metabolic derangement if you leave your testosterone off. It's not just for sex, not just for libido. Um, I Testosterone, estrogen, and progesterone all play a role in our overall physique. And I think when you see someone that looks very aged, they're sagging, they're wrinkled, their cells are desiccated. They've been missing all of them, including testosterone. I think it keeps us together, keeps it tight.
It keeps it tight. That's right. Yeah, I've become a bigger advocate, and now also using it in areas where we potentially can't use estrogen. One of which I want to bring up later. But when it comes to testosterone, there is so much controversy. And you and I, before we hit record, we were talking about pellets and testing. So give me a sense of how you have adapted this into your practice and how you find really the best sweet spot as far as levels and testing and getting women where they need to be.
So with testosterone, just like estrogen, with the exception, I probably have one woman out of 1,000 women that is on an injection, and it's because she came to me from someone else. So I'll discuss that in a minute. But overall, it's replaced as a cream. I look at not just their testosterone level, but I also look at the cortisol and the breakdown components of our stress hormones. I look at DHEA, and then I look at, is estrogen and progesterone balanced? For the most part, a woman with a testosterone around 30, 35 with abnormal estrogen progesterone, I will correct their estrogen progesterone profile and then reassess, make sure that the testosterone stays in that early sweet spot.
Mm-hmm.
You don't have to overshoot testosterone. I just want to make sure that if your cortisol is very elevated, I want your testosterone at least in the early mid range, not too low and not crossing that mid range marker, but kind of like right in that second quarter area. Again, it's because it's not just the presence of testosterone, it's the balance of the other with it. I use a cream. I generally, and again, it depends on the person's number, but I generally start them around 0.5 milligrams daily on the cream. So, and again, I'm a cash based clinic. So for the most part, I might do a higher concentration with a smaller, amount of the cream. And you can dose it up. That's why I love cream. I can increase you. I can skip you every third day. I can do it twice a week. It's very easy, as opposed to the moneymaker pellet people who, overcharge, overdose, and cause extreme problems when they overdose with that.
Yeah. What kind of problems have you seen in people that have had pellets?
I had a man call me and said that his wife was too aggressive. I had another man call me and say that his wife looked like she got hit with a wiffle ball bat on her butt. That was fantastic. But the women complain of, because the dose is too high, they'll complain of acne. I actually had to point this out to a woman. She had a very deep voice. And I said, I'm just meeting you, ma'am. And we had spoken for a while. I said, do you feel like your voice is deeper than it was before you got the pellets? And she sat in my chair and sang a little. And she said, you know what, you're right. And I told her, I said, unfortunately, I don't know that you will go back to a normal voice. She was thankful that the pellet could wear off its other effects and that I was going to help her with creams later on. But when those pellets are given to a woman, included with testosterone in them, I don't think that the consent that's being signed, I don't think that it's fully stated that you could be virilized. Your voice can deepen and may not go back to normal. You can have clitoral enlargement. I had a woman come in, she had high dose pellets, clitoral enlargement, severe acne that took almost a year to go away on one of my patients, aggression. I had a woman lose her job because she couldn't control herself after those pellets were put in. That was really bad. But all of the normal things that get stereotyped for excess testosterone, I've seen it in a woman that's been on a high dose testosterone pellet.
Mm-hmm.
Mm-hmm.
Yeah, I don't have that many patients because my patients are generally older. They're not pursuing pellets. I've had a few, and yeah, same thing. Really high levels. I've had women come in, and I've seen their testosterone levels be 3, 4, 500. And I'm like, well, you have more testosterone than your husband, and they would come in as a couple. Like you have 4 times the testosterone of your husband right now. which could create some relationship challenges. Um, so then I would love to then let's add testosterone and estrogen, and let's do it sort of through the context of another topic that I wish I didn't have to deal with, but unfortunately is really common. And this is around the area of breast cancer. So do you have women that come to you with either a history of or active breast cancer with a desire to talk about hormones, and how the heck do you manage that?
So, years ago, um, and I had probably just built my office and I was still working at the hospital and I was still teaching. So this was maybe 2014. A woman came to me from New York and she was referred by one of the higher ups in A4M, one of the founding people from A4M. And she had breast cancer and she was in remission probably like 10 years at that point. And she said, I was referred here. I moved down from New York and she had a history of breast cancer. And so I was taken aback for a minute and I actually reached out to Pam Smith and, my higher ups and get the blessing. But it seemed that the research at the time and still shows that if you are more than 5 years out, you educate the patient, but when the cancer is there and the cancer is present and it has the receptors and you give extra estrogen, then if the cancer has positive estrogen or progesterone receptors, then by default a cancer would grow. But if the woman has had a mastectomy, had the actual tissue removed, has had chemo, or has actually just been in remission, maybe no chemo or anything, has been in remission with no problem for 5 years or greater, their risk of it coming back with estrogen therapy, there's no increased risk if you're going to, again, because you still have estrogen in your body.
Yeah.
So there was no increased risk. And in addition, the presence of the testosterone actually prevented the recurrence. And in women that actually had an actual mass present, the testosterone was shown to either not let it grow or it actually shrunk the size of the tumor. So that right there, I currently I probably have maybe 5 or 6 women that have had their own breast cancer that are now back on hormone replacement and varying ages from 45 to 60, 65, 66. They're on estrogen, progesterone, and testosterone.
Yeah. I have a few as well, and it's a very challenging conversation because they're scared of recurrence as well, right? It's not just my fear and your fear around it. It's, they're scared of recurrence. Recurrence has not as good of a prognosis as an initial diagnosis.
Right.
So, there are not many doctors who are willing to do that.
Right.
And I'd like to bring up too, because again, I'm dealing with a population that has a clear other diagnosis, right? If someone has severe osteoporosis, what's the benefit of adding estrogen, adding testosterone, adding progesterone? They all have impacts on bone. And so then we have to do, risk benefit analysis, but it's so hard when the oncologists rail so hard against it. And
Yeah.
to say you should never use it. And we've even had conversations to say, well, what about testosterone with aromatase inhibitors? What if we just eliminate estrogen altogether, but give you testosterone, which is protective of breast cancer? And still oncology would say no, in these particular cases. So I wish there were more studies on using this, but it's just not an area where there seems to be interest in research, which is really unfortunate.
Yeah. That's another frontier. There's a Finnish study that a group of people that I have a private patient that's part of this research group, and we're kind of kicking around the idea of how to maybe get some enrollees. And people have their different demographics, their different diagnoses, their different pathologies. But it's difficult to sign a human up for the research, but it's difficult. So I don't think people understand. It's like, we have this data. It's shown that there might be a risk, but there's no increase. There's no different risk if I still give you the same estrogen that's in your body. Also, this testosterone is protective. I want to protect you from the recurrence. I want to protect you from a mass growing. It's difficult to enroll them.
Yeah, sad. But we'll just deal with them one case at a time. Do the best we can.
Yeah.
Yeah.
And then to that point, since you're the expert on this one, and I kind of wanted to get your take on it with the supplement the replacement of estrogen and testosterone as far as bone health. The testosterone is protective against the breast cancer. But if someone has osteoporosis to the point where they had a previous fracture, if they cannot have estrogen, at the minimum, I would say testosterone replacement to stop the breakdown of bone is warranted, right?
Yeah, and I find too, and there are not good studies on this, but I find that when we use testosterone, we see more of that anabolic effect, which would be on the osteoblast side. So we'll see the P1 and P is the biomarker we use to measure that, and we'll see P1 and P rise with testosterone. So we're using testosterone frequently off label for the FDA that's listening,
Yeah.
but it has receptors everywhere, just like estrogen, right?
Yeah. Yeah.
Yeah.
Oh, I did a summit last year in New Orleans. I'm going to do a second one in August. But one of the security guards, she was a woman in her late 50s, and she always wore this brace. I know her from the area. Turns out she had gone through menopause when she was in her early 40s. So now she's almost 60, and no one to the moment of my conference last year had spoken to her about hormones, hormone health, bone fractures, or anything. And she said she has 2 vertebral bone fractures and she lives in constant pain every day.
Yeah.
And that's why she wears the brace to kind of help literally brace her body to not be in more pain. And I almost cried, Doug. I mean,
Yeah.
the fact that traditional doctors don't want to learn that extra information and they're letting thousands of people down, you know.
Yeah. Well, and I think it's millions of people and it's worldwide. And that's why,
I'm saying each
yeah,
physician, like you impact thousands, and that impacts, and that impacts, and that impacts. We all have to use our voice. And if the traditional doctor has their hands tied and they're married to a system that doesn't allow them to help, then by all means, please refer them to someone like you or I. Go to A4M, look up functional medicine provider, something. Don't let your person just wither and die a painful death eventually.
yeah, this is a really challenging space. I'm glad you said that because we have, millions of views. I get comments worldwide. Osteoporosis is like a forgotten disorder.
Yeah.
Amazing.
And so a little digression. My mother had leukemia when I was a baby. And so this was in the 80s, and the time frame of chemotherapy and the aggression of the chemotherapy that she went through left her with early onset osteopenia, osteoporosis. So she had bone fractures, she had disc issues. She ended up having 2 surgeries in the 80s, and then they said, we can't touch you anymore because your bones are too brittle. It's going to cause more damage. Long story short, she ended up having a few more surgeries, but she lived in constant bone pain. And if anyone knows someone that's had bone pain, it is probably one of the it's the most horrible thing I think you can have, because it's every single minute of every single day. It never goes away.
Yeah. Yeah. I definitely hear those stories. Sad. Well, let's cheer up this note. So, so I think that's a great conversation. We've been going for a little over 35 minutes. So I say, let's call this here so we can make this digestible. But tell people how they can learn more about you, your message, and how they can find you.
So I think the most accessible spot for your listeners would probably be Instagram, and my handle is at Dr. Bonnie Gasquet, Gasquet. So Instagram's a nice spot to find me. Just send a DM, and then I can direct the person to which office would be the best one to contact. I'm always up for a question. You know, some people, it's just as simple as, hey, do you have someone in my area that I can talk to? And I'm so happy to point them in the direction of who they can. I'll even look it up and send you the name. But I think to anyone who's listening, if you're a woman and you're actually comprehending this information, you should at least know where your hormone levels are. If your mother or your aunt or your in-laws or anyone are still alive and you want to protect their health later on, they should know where their hormones are. And your men too. Don't forget about your male component. But definitely, knowledge is power.
For sure. I would argue knowledge is potential power. And then you got to take that action, which is actually get the blood test. And that's a great call to action. So thank you, Dr. G. This has been a stimulating conversation. I'm sure one that we'll have again in the future, hopefully in person at an A4M event.
Yes. Yes. Oh, are you coming here for I'm across the street from the conference right now from the
Yeah,
conference.
I'm speaking this spring. Yeah.
I will see you in 3 weeks.
Okay. Sounds
Oh,
good.
I'm so excited. Okay.
Okay. All right. Take care, Dr. G.
All right. Thanks. We'll see you.
Thank you so much for watching this interview with Dr. Bonnie Gasquet. If you're interested in more information about osteoporosis and estrogen specifically, take a look at these two videos. We have two videos that are specific to estrogen that we can continue to have this discussion around estrogen and bone health. So take a look at those. And remember that osteoporosis isn't the end, but deciding to reverse it is a beginning. I'll see you in the next video.